Okay, so as usual, we begin by probably reminding ourselves which words we can use to describe the gross morphology. Or if someone says we didn't do the teratoma, so maybe we can just do it quickly. Okay, so given this picture, let's use our template to sort of describe the words that, or to describe the gross morphology. So what do we see in this picture? Colors, features, anything. What do we see? Yes, we see this sort of yellow, tan yellow segment. That's nice. What else do we see? I can see sort of reddish areas, right? Yes, yeah, I can see reddish areas. So a coarse appearance, exactly. Yeah, I agree as well. A coarse appearance. Yeah. So now this is looks like spot of red hemorrhage. Yes. So we said for red, when you see red, that probably infers hemorrhage. When you see black, that probably infers necrosis. And when you see red, that not white, that probably infers fibrosis. So maybe we can keep that in mind as we proceed, because we'll describe a lot of these morphologies. Okay, so that is a teratoma, benign cystic teratoma, and its classification, it's a germ cell tumor. Let's move to the testis. Now, describe the gross morphology. What can we see in this sort of picture? Using the template we described earlier. Yes, I can see white areas, well circumscribed lesion. Yeah, definitely. What else? Let's talk about the stock. Yes, black exudates, blackish areas, so necrosis. I agree. I agree. And also at the bottom of the organ, there is sort of black areas signifying necrosis. You guys are doing well. Now, let's move to the picture below that and describe the morphology on that. The red areas, probably hemorrhage. Yeah. So, what is the underlying pathology? Pale areas, pale lesion with hemorrhagic spots. Exactly. I agree. I agree. Yeah. Do we see like cystic appearance? I'm just asking. Okay, so what is the underlying pathology? Yeah. Okay. Sawa. So maybe that you can put that in mind as well. Now, so what is the underlying pathology? It's a seminoma, the most common testicular tumor that resembles an ovarian dystaminoma. How it resembles an ovarian dystaminoma, I think, is because of its histology. So under histology, what do I expect to see? So maybe I'll expect to see a fried egg appearance under histology. Okay. So state the state microscopic features of the above pathology. Maybe we can mention them and put them in the chat. I've already said one, fried egg appearance. Any more microscopic features that we'd expect to see? Any ideas? Okay, so you'll expect to see the fried egg appearance first. Also, for the seminoma, usually have a uniform single population of cells that resemble spermatogonia. You have large polyhedral cells with a distinct cell membrane, clear glycogen-rich cytoplasm with large central nucleus. That's why it has this sort of fried egg appearance. It has a prominent nucleolus, that is the nuclear material inside the nucleus. Stroma contains lymphocytes and plasma cells with few mitosis, and ill-defined granulomas with giant cells in the stroma. Okay, so I think this is, you can like take 2 or 3 that are very prominent. So maybe the fried egg appearance, few mitosis, and probably the single population of cells that resemble spermatogonia. I think those are a bit straightforward. Okay, we move to the next question. Identify 2 immunohistochemistry markers that are positive for this pathology. So you have the c-KIT and the plasma alkaline phosphatase. So move to the next question. Now, let's identify this pathology. What do we think this could be? Let's put our responses in the chat. Someone says testicular torsion. Why do you think it could be testicular torsion? Maybe try back up your answer as we wait for more answers to stream in. So there's only that one answer, testicular torsion. And wanting to see the justification why we think it could be torsion. So when you look at this picture, something has happened to one of the testicles, undescended testis. So someone says undescended testis, and I agree. So when you look at this picture, something has happened to one of the testicles. And usually for testicular torsion, you'll probably have both testicles descended, but you'll have now the clinical symptoms like pain, and once like you excise, you'll find necrosis. But this is is undescended testis. What is the medical term for undescended testis? Exactly, cryptorchidism. Now, so this is failure of either one or both of the testes. He said. So what happens usually? You have impaired spermatogenesis. This is because the temperature in the body is a bit higher than what you'll find outside, and the optimum temperatures for sperm production are less than 37 degrees Celsius. You can have normal testosterone levels because the Leydig cells are mostly unaffected by temperature. So you'll find that these people might have sort of infertility issues, and it's not because the Leydig cells are not working. It's not because you don't have testosterone. It's just because there's no optimum production of spermatogonia sperms because the temperature is pretty high inside. It does not favor production of sperm. Now there's a question. So most cases of this will resolve spontaneously. Otherwise, use surgery to sort of make them descend. And what is the name of this surgery? Yeah, Pepsi. Now, yeah, I think that's it. Any questions on that? Someone tells me to describe how it looks in a child. I don't know what that is. but maybe Nate can help us.
What? Sorry, I've not got your question.
Someone asked I asked me to describe or mention this looks, oh sorry, okay, fine, sorry, let's continue. Okay, so peripheral nerve sheath tumors. Let's identify this pathology. What do we think this pathology is? Where you have sort of this multiple outpoachings from the skin. Let's put our answers in the chat as usual. What do you think the pathology here would be? Neurofibromatosis 1. Great. So for neurofibromatosis type 1, what is the cause of neurofibromatosis type 1? If anybody knows in the chat. So the main cause of neurofibromatosis type 1 is mutation in the neurofibromatosis type 1 tumor suppressor. Now what happens, you have this classical presentation of these sort of outpoachings. Now, name the other tumors that are associated with this neurofibromatosis type 1? What other tumors can be associated with neurofibromatosis type 1? Tubercular sclerosis, maybe not, but it's under sort of the same umbrella of diseases. But it's not tumor that arises from neurofibromatosis type 1. Schwannoma, yes, schwannoma, but which type of schwannoma? I agree, there could be a schwannoma, but which type? Pheochromocytoma, yes, that's true. Usually pheochromocytoma. And that's like part of the clinical presentation sometimes. So pheochromocytoma could be there. Any other? So you have dermatofibromas, bilateral optic nerve glioma. Yes, that's correct. That's right. So bilateral optic nerve gliomas. So I think this is classified by schwannomas. And also you have plexiform neurofibroma. Yeah, that's the acoustic neuroma. But acoustic neuroma, maybe we'll see it in another neurofibromatosis, but it's a tumor present in one of the neurofibromatosis. Now, also other presentation could be pheochromocytoma, and then you have something called cafe outlet spots. That can also be a presentation of neurofibromatosis type 1. Now, for neurofibromatosis type 2, what are some of the tumors that are related to it or associated to it? Someone has already mentioned bilateral acoustic neuroma. Maybe we can get a few more, like 2 more. Yeah, so we have the bilateral acoustic neuroma, ependymoma, correct. That's great. And schwannoma, schwannoma, and multiple meningiomas. That's great. So they are the ones here on the screen. So maybe you can take a point of noting them down. And don't confuse the ones for neurofibromatosis type 1 and neurofibromatosis type 2. We can try coming up with a mnemonic. Let's see if it works. Okay, so for type 1, dermatofibromas, bilateral optic nerve gliomas, plexiform neurofibroma. For type 2, we have bilateral acoustic neuroma, multiple meningiomas, and ependymomas. So maybe you can see the type of lesion that is produced by neurofibromatosis type 2 in the picture below. They are not as numerous as type 1. There we go. So this is neurofibromatosis type 2. So maybe if you find this in an exam and probably you're not sure, you can write cutaneous neurofibromas if they ask you to mention what those spots are. Like you see these circle things, yeah, these elevations on the skin. If you're not completely sure, just call them cutaneous neurofibromas. So let's move to the next. Okay, so here we see a part of the body. What part of the body could this be? The colon, great. And then there's something of a growth. Yeah. This growth is coming down from, I guess, what is the roof of the colon that we've been told. Now, let's try name that outpouching. What could this outpouching be? What is the pathology? A polyp, great. So this is a Hamartomatous polyp. Now, there are some conditions that are seen, or there are some conditions that commonly present with Hamartomatous polyps, or there's some conditions where you have them, you probably have Hamartomatous polyp. So, what are some of these conditions that present with Hamartomatous polyps in the colon? Exactly. So we have Peutz-Jeghers syndrome. Correct. Yes, and juvenile polyposis syndrome. That's great, guys. Maybe for a description, what is a juvenile polyposis syndrome? So basically, both of these syndromes that we've mentioned, maybe someone can put them in the chat in the full names. Peutz-Jeghers syndrome and juvenile polyposis coli, both of them are autosomal dominant syndromes. Now, for juvenile polyposis, from the word, it comes from, or it mostly affects children typically below the age of 5 years old. And it features Hamartomatous polyps in the colon, stomach, and small intestines. For Peutz-Jeghers syndrome, it's about the GIT. So anywhere through the GIT, including mouth, lips, hands, genitalia, probably get some Hamartomatous polyps. And here, in Peutz-Jeghers, it's associated with a higher risk of breast cancers and GIT cancers, such as colorectal cancer, stomach cancer, and bowel cancers. So basically, that's what Hamartomatous conditions are. They present with Hamartomatous polyps. Usually, Hamartomatous polyps don't have a high risk of malignancy. That's why we specified that in Peutz-Jeghers syndrome, there's a high. This one's a special because they have sort of a higher risk of becoming malignant. Any questions on that? Great. So maybe we can move to the next. Great. Maybe let's describe the pathology. What can you see in these pictures? Describe the gross morphology. Maybe Nate can zoom out a little bit so that we can see the whole thing. There's hemorrhage because of the the black sort of areas. Sorry, not the black, but the reddish areas. Yes, there's also necrosis. I agree. areas of necrosis. I agree. Maybe let's talk about the organ below. It has some characteristic indentations. What could we call them? Could we say the organ is notched? Yeah, let's say the organ is notched. Also, there's this sort of whitish organ, right? In the middle there, right? So you can say like there's sort of a whitish appearance or organ or whitish matter. Okay, so what do you suspect the organ below could be? That notched organ. Someone has said the spleen. Yes, and I agree. Now, when you talk about the spleen, when you kind of look at where the spleen is, what are some of the organs that are adjacent to the spleen? Maybe let's start to the upper part, to superior to the spleen. What do we have? Okay, so someone has already answered. So you have the stomach. Yeah, you have stomach that is medial, right? What else do we have medial to the spleen? We have the pancreas. Great. So on this picture, yes, pancreas, correct. You guys are doing well. So in this picture, we see that this spleen, we're observing it, and usually we know that the organs to the medial aspect of the spleen are either the stomach or the pancreas, right? So this picture taken of the spleen, if we side it anatomically, we find that this is the medial part or the medial aspect of the spleen. And we've already established which organs are found in the medial aspect of the spleen. So maybe we can ask ourselves, which organ is most likely to look somehow similar to this? Or which organ is this most likely to be? And why? I would say the whitish grayish appearing organ would be the pancreas. Why? Because probably the color, right? What color is the pancreas? Or someone has reminded us. I forgot to ask, what do we think the pathology could be? So someone tells me pancreatic tumor. Correct. So we were trying to establish which organ this is, right? And I don't know. Does everybody have the same color of pancreas? Someone says ductal adenocarcinoma. That's a good try. Any other tries? Okay, so maybe I'll answer it. So usually the pancreas is usually sort of grayish looking, sort of pinkish looking, right? And from these organs, what you can see, there's no pouch-like organ, right? On this picture, anywhere that we look, we expect to find two organs, yeah? Either the stomach or the pancreas. And in this, we know that the stomach is sort of a pouch-like organ, yeah? Which will be easy to see. But in this picture, I don't think we can see this sort of pouch-like organ. Also, the pancreas is sort of whitish, sort of grayish, sort of pinkish in color. And I think that's what is closely resembled in this picture. So that's why I went with it's probably a spleen. No, not a spleen, but a pancreas pathology. Right? That's how we eliminated. So what pathology of the pancreas could this be? Someone tells me a tumor, right? So this can either be pancreatic neuroendocrine tumor or an islet cell tumor. So having said that, what are some of the examples of tumors that can affect the cells of the pancreas? So maybe maybe we can start by which cells or which type of cells are found in the pancreas. Maybe we can list them down. Then from there we can describe some of the tumors that can be found in those cells. So which cells do we usually find in the pancreas? You have beta cells, correct? Alpha cells, delta cells. Great. So if I have a tumor arising from the alpha cells, what do you expect to call this tumor? Maybe we ask ourselves which hormones or enzymes are produced by the alpha cells in the pancreas. So alpha cells produce glucagon, correct? So the cells, the tumor will be called a glucagonoma, correct? Yeah, we have B cells. We mentioned B cells. So B cells produce insulin. So the tumor will be known as an insulinoma. You guys are doing well. How about delta cells? What do delta cells produce? Mhm. Yes, so somatostatinoma. You guys are doing well. Okay, so those are the examples of some tumors that this might be. So because we've said these are isolate cell tumors, and some of the cells that are present in the pancreas are alpha, beta, and the delta, and we've come up with the pathologies that will affect each of those cells. So for the alpha cell, we said a glucagonoma. How will this a patient with production of how will a patient with a glucagonoma present? So usually a glucagonoma just means that they're producing excess glucagon. So they might present with what we call the 6Ds. Hepatitis, diabetes, which is hyperglycemia, this DVTs, decline in weight, and depression and diarrhea. So that is a glucagonoma. For the insulinomas, here we have overproduction of insulin, right? So you have hyperglycemia. You'll see what you call the Whipple's triad. The Whipple's triad includes low blood sugar or blood glucose, symptoms of hypoglycemia, such as syncope, diplopia, and lethargy, and also resolutions of the symptoms once the blood sugar stabilizes. Now, there is also what we call vipomas. These are nerve fibers. These are tumors that affect the nerve fibers innervating these sort of cells. So if I have a nerve fiber, sort of transmitting impulses to the alpha cell so that they can sort of fire and cause it to produce these enzymes, it means that when they are not working, those nerve cells, or they're affected by tumors, these cells won't work normally. And so tumors affecting these nerve fibers innervating these islets are what we call vipomas. Okay, so I think we've answered that. We can move to the next one. Talked about somatostatinomas. Okay, so here we see something happening. What organs could this be? Maybe what organs can we see in this picture? We can see the trachea. Can we see the esophagus? Can we really see the esophagus? You can see the larynx. What else? We can see the tongue, right? Tongue, epiglottis, trachea. Great. So we can see all these pathologies. And then something happens, and we can see something foreign. And where is this something foreign lodged? Yes, it's sort of lodged in the trachea, larynx, thereabout. So if someone lodges something in someone's trachea, what do you expect to happen to them? They will die. Due to what? What will cause them to die? Asphyxia, right? So what will be the cause of death? Yes, asphyxiation, right? So this person was asphyxiated or was choked to death, right? So they were choked to death. That is what we call asphyxiation. Maybe we can try and ponder over this. What could be the manner of death? Is this a natural or an unnatural death? Unnatural, unnatural, yeah, I agree as well. Now, what is the mechanism of death? I will probably think of things like maybe death due to hypoxia, right? Because once you're asphyxiated, you're not able to take in air, so therefore you die due to probably hypoxia. But the question was asking, we identify the cause of death, and so that was, we determined it was asphyxia, and it was mechanical asphyxia due to aspiration. Oxygen deprivation due to obstruction, I agree. That's correct. I think you guys are doing really well. The following. It's nice to see. Let's move to the next question. Hypercapnia. I'm not sure what hypercapnia, but it could be. Maybe you can put explanation of that in the chat. Dysphagia. Dysphagia. So basically, I don't think it's dysphagia, because dysphagia, what is the definition of dysphagia? Dysphagia is just difficulty in swallowing. So difficulty in swallowing itself in this case, um, I don't think will lead person to die, right? And so I think the main thing we ask ourselves, what really caused this person to die? Was it because he was unable to swallow, or is it because they were able to swallow but it went to the wrong tube? Right? Aspiration. So someone else is asking what aspiration is. So aspiration is when you sort of have I think fluids going down the wrong drainages or pipes. Yeah, so someone has put it in the chat. The food contents enter the trachea. That's what we call aspiration. Correct? Good. See the chat is active. It's nice to see as well. Let's go to the next question. From this pathology, what can we see? Maybe someone can describe what we can see on the calvarium. We can see bone lesions, and these lesions look punched out. And someone has already told us this lesions are lytic, and they are multiple. Great. So I think you've already answered the whole question. So we've described the abnormality in the skull. We've said there are multiple, lytic, well-defined, patched out lesions of various sizes scattered throughout the skull. Done well. I don't think we need to ponder much over that. Now, what could be the pathology? What could be the illness affecting this? Multiple myeloma, correct. So for multiple myeloma, What is multiple myeloma? This is when you have malignant plasma cells. Yeah. Now, how will I diagnose multiple myeloma? What are some of the tests I will carry out to diagnose it? I will do Brashos. I also do Benz-Jones. Also, I think Bradshaw is just Benz-Jones. Yeah. I'll do urine protein electrophoresis. I agree. Upper is someone peripheral blood film to sort of look if and see if I'll get the abdominal plasma cells. ESR, yeah, to see how much I'm clotting or not clotting. The sedimentation of red blood cells is there. See, yeah. So immunofluorescence, I think you guys have done well. So we can use urine protein electrophoresis, serum protein electrophoresis, ratios to show the presence of Benz-Jones protein. Someone said BBF to show Rolu formation, erythrocyte sedimentation, yeah, which is usually high, complete blood count to show if there's anemias, and in advanced cases, neutropenias and thrombocytopenias, and to see if there's bone marrow, for bone marrow aspirates, to see if there's abnormal plasma cells. Now remember, multiple myeloma is one of the plasma cells, is scariasis. Now, maybe for the principle behind the Benz-Jones test, when you do a urinalysis, it will usually show antibody light chains. These are what we call Benz-Jones proteins when you dip them in the dipstick. Now, yeah, that's it. What are some of the clinical features that multiple myeloma presents with? Vertebral pain, I agree. Recurrent infections, I'm also in agreement with that. Any more responses? Weight loss, fractures, yes, fractures. Renal failure is a big one. Kidney issues, renal failure. So fatigue, pallor, dizziness, yes. So for someone said fractures, I'm being told fractures maybe, maybe it's bone pain, but not. Oh yeah, fractures is there. As the person mentioned it, actually fractures is there. What reduction in height? Yes, because the vertebral or the vertebral column sort of collapses, and therefore you find you have reduced height. So for this, there's a lot of answers there, but maybe I'll give you a mnemonic. Use the mnemonic called CRAB. So for CRAB, you have hypercalcemia. So the hypercalcemia, the cal in calcemia, stands for the C. So the C is for hypercalcemia. This is caused by the increased cytokine secretion. Remember when we were discussing last time, we were talking about a girl with multiple lesions, right? And they were presenting with something almost similar. I think it was multiple myeloma. And we said for this multiple myeloma, we have production of pro-osteogenic cytokines or pro-osteogenic products such as interleukin-1, tumor necrosis alpha, and rank L. So these were the ones which will cause the bone lesions. Now, hypercalcemia is hypercalcemia, right? Due to the secretion of some of these prosteogenic factors by malignant plasma cells. You also have renal insufficiency, someone mentioned, for the R, anemia for A, and bone lytic lesions for the B. So maybe you use that mnemonic to be easier. Someone asked for hyperuricemia. Is hyperuricemia a feature? I'm not sure. Maybe someone can confirm. CNS. Maybe someone can confirm that as well. Hypercalcemia, yes. Anemia, yes. Bone pain, yes. Fatigue, pallor, dizziness, yeah. Easy breathing, of course. And kidney issues, yes. So maybe we use mnemonic CRAB. Hypercalcemia, renal insufficiency, anemia, and bone lytic lesions. Any questions? Move to the next pathology. So what can you see in this image? Widened sulci. So there's narrow gyri, but this narrow gyri, right, is not global on the whole brain. There are specific segments or specific lobes of the brain that have been affected by this pathology. Which are the lobes of the brain that have been affected by this pathology? The narrowed sulci and the widened, the narrowed gyri and the widened sulci. We have frontal lobe and temporal lobe. Exactly. So the frontal and temporal lobes. Now, what will we call this pathology that only affects the frontal and temporal lobes? What do we call this pathology that narrows the gyri and widens the sulci only in the frontal and temporal lobe? I see responses. Alzheimer's. Now, for Alzheimer's, we say that the whole brain will have narrowed gyri and widened sulci. So for this, we've just said only two lobes are affected. That is the frontal and temporal. So the correct response will be frontal, temporal, lobar degeneration, right? So it's important to see where or which lobes have been affected. If it was all the lobes looking widened and flattened and narrowed, that will be Alzheimer's. But since it's only the anterior lobe, the frontal lobe and the temporal lobe, is why we go with the answer as frontal temporal lobe degeneration. So note the parietal lobe, occipital lobe are spared. Name two clinical distinctions that allow for diagnosis. So what are some of the features that lead you towards a diagnosis of frontal temporal lobe degeneration? So we have personality dementia. The dementia, mostly Alzheimer's, but I'm not ruling it out completely. Maybe they are apathy. Maybe the more characteristic ones are personality and behavioral changes due to the affected frontal lobe, and aphasia due to the affected temporal lobe. We proceed to the question. Okay, let's describe this pathology. What can we see grossly? Does this organ look cystic? Yes, so there are multiple cysts. Are there areas of hemorrhage and necrosis? Yeah. Mhm. So what do we suspect this organ to be? Kidney? Mhm. Any other choice? The liver. So this is a liver. Maybe the upper part can sort of help us identify this organ. So for the organ above, they are like have two lobes, right? When you look at the organ at the superiormost part, you'll notice that there's a line dividing the left lobe from the right lobe. So that's why we came up with the identification of the organ as liver. And this liver has multiple cysts. So what will you call the pathology? What could this pathology be? Yeah, polycystic liver disease. Polycystic liver. Okay, so now we have same organ, different pathology. What could be the pathology for this? Liver cirrhosis. Great. Maybe we can describe the gross morphological features for this pathology. Degenerative nodules, yes. So those two small circular things you can see on the top are what we call the nodules. Do you think that's the main sort of what we can see? There's also something that I can see on sort of bottom right aspect of this organ. It's like a different color. What is this color? What is that change? Fibrosis. Mhm. Maybe that's the microscopic features. That's why you're able to properly identify or appreciate the fibrosis. But the right part, you can see that the color has sort of changed to yellow. So the usually red, pinkish appearing organ is now yellow appearing. What do you think that could be? What could be causing this yellow appearance of the liver? Someone says bilirubin. Now, we're getting close. That's bile, right? The bile pigment. So bile pigment, bilirubin, actually correct. Also, the surface is irregular, of course. Someone already told us that. So, now, for the microscopic features, someone help us describe the microscopic features. We already mentioned one, the regenerative nodule, and the fibrous band. So I think, okay. State the clinical features and complications of the above pathology. So what are some of the clinical features that we expect people with this pathology to come with the clinics, to the hospitals? Mhm. Portal hypertension, correct. Jaundice, mhm. Splenomegaly, mhm. Ascites, yes. Hepatomegaly. Well, for hepatomegaly, the liver could actually even shrink in such people. So hepatomegaly, question mark. Pruritus, yes. Yes. Spider Navy, yes. Agree. How about coagulopathies? Yeah. Hepatorenal syndrome and all that. I think you guys have done well on that question. We move to the next one. Any questions on that? Great. Hematemesis, yes, because of the varices. Great. Now, next we can see there's sort of a cell, and this cell has an inclusion inside. What could this inclusion inside the cell be? And what could this cell be? Or which cell or which organ does this cell come from? We'll get that from there. So this is a hepatocyte, right? And this hepatocyte has an inclusion. What is this inclusion inside the hepatocyte? Inside the hepatocyte. Mallory bodies, yes. So Mallory tank bodies. For Mallory tank bodies, when do we find them? In what disease or in which pathologies do we find Mallory tank bodies? Alcoholic cirrhosis, exactly. Great. So Mallory tank bodies usually come about when you have degeneration of hepatocytes, and this is usually due to insults like alcohol, which lead to cirrhosis. Usually when the hepatocyte is damaged, you'll get these eosinophilic cytoplasmic inclusions that are very prominent in the hepatocyte. So that's when you get Mallory tank bodies. Now, below that, the next question, there's an almost similar appearing pathology, but it's a bit different. Now, what could this pathology be? Yeah, so this is Councilman bodies, and they're caused by viral hepatitis. So I can see the chart, someone has given us a mnemonic. So for this mnemonic to work, usually we presume that probably this photo is the one which will be tested. So or by luck, we hope that this photo will get into the examiner's hands and to our booklets. So what happens, at the top right hand corner, there's sort of this whitish cell or whitish space. So that's what we use to help us or to guide us to know this is a picture of Mallory tank bodies. It's not that this is the pathology, this is just the mnemonic we use. So when you have a white inclusion at the top right hand of the picture, that is Mallory tank. That's a picture demonstrating Mallory tank. But if this inclusion is at the top left, or that white space is at the left side, that is Councilman bodies. That's why Nate has put that in the chat box. So someone has asked us to sort of point at the bodies. The bodies are those blackish appearing things inside those cells. So what these things are, they're just intermediate, they're tangles of intermediate filaments that are visible as eosinophilic inclusions in the cytoplasm. So if you have cells, like these cells are the ones which look like honeycomb appearance, sort of many honeycomb appearance, which are pinkish and all that. But inside these pinkish cells, you see that there is this sort of entangled masses or these are entangled filament masses, and they appear eosinophilic. So those pinkish masses, yeah, the darker masses are what we call the bodies or the Mallory-Denk bodies. Same for cancer bodies. So those darkish patches that you can see, those are the bodies. Yeah. So maybe we can pick up from there next time.